Hello everyone, I am Preeti. Welcome to my channel Dialogue with Doctors, in which I engage in an extended dialogue with two medical doctors. In each episode, we discuss threadbare the various aspects of a major disease or disorder. Today's episode is the second part of a two-part series on coronary artery disease. In the first episode, we had discussed what exactly is coronary artery disease. How does it develop? What are the signs and symptoms to be alert about? And what are the risk factors which make it more likely for us to develop the disease? And how is the disease diagnosed? In today's episode, we would be focusing on the remaining areas. Those are treatment options, recovery and rehabilitation, and prevention. So for the panel discussion today, viewers, we have a stellar duo of a cardiologist and a cardiothoracic surgeon with us. The first doctor on the panel is Dr. Vinod Sharma. Dr. Sharma is a distinguished cardiologist and head of the Department of Cardiology at National Heart Institute, New Delhi. The second doctor on the panel today is Professor Abid Geelani. Professor Geelani is head of the Department of Cardio-thoracic Surgery at B Pant Hospital, New Delhi. Viewers, both these doctors are stalwarts in the medical profession and they were present to answer our questions in the first episode also. So without further ado, let us plunge into the discussion. Let me pick their brains and let's get to know all about coronary artery disease. Stay tuned till the end of the episode. Know everything about the disease. Dr. Sharma, we'll begin our discussion with the issue of treatment today. In the last episode, you had made a distinction, sir, between stable and unstable angina. In order to jog the memory of my viewers, I'd just like to sum up. I think you had described stable angina as the discomfort or pain in the chest, which a patient experiences while performing some activity. It could be walking or climbing stairs. And unstable angina, please correct me if I'm wrong, you described it as experiencing these symptoms even while resting. So, sir, my question to you is, if a patient is diagnosed with stable or unstable angina, what is the course of treatment for such a patient?
When we talk about the stable versus unstable angina, stable angina obviously is the initial form of the disease. When the person gets pain or discomfort on a fixed activity, say like walking after 200 meters, 300 meters, or walking or climbing the stairs. But if he walks on the plain ground, he may not get. If he walks a little distance, he may not get. Contrary to that, unstable angina indicates it's a more severe form of the disease, where he starts getting discomfort which is more frequent at rest, provoked by little activity. So that is unstable angina. Once we have assessed it clinically and baseline investigation has been done, and electrocardiogram doesn't show any evidence of myocardial infarction, because sometimes person may have had infarction, heart attack, and then they get post-infarction angina. So once we rule out that, then thereafter the treatment component comprises precisely two parts. Part one is that there is a set of medication which are meant to control the pathological process which is going on inside the arteries of the heart. That is because it is a mostly nerving of the artery due to the cholesterol deposit. On top of that, there is a clot formation. There is a so-called spasm, constriction of the artery. So to address this, we have set up medication which are antithrombotic, which are meant to prevent the clotting, antiplatelet, again to prevent the clotting. Then there are lipid-lowering drug which lower the cholesterol, as well as they have some anti-inflammatory property. And there are coronary dilators, nitrate group of drug, and beta blocker. Beta blockers mainly are concerned with reducing the oxygen demand of the heart. So we start with these basic treatment when the person has stable angina. Unstable angina, more often they are the sicker patient. They may need hospitalization. And in them also, beside these drugs, we get into the intravenous medication, that is intravenous nitrate, intramuscular or intravenous antithrombotic drug. So that is the first basic pharmacological treatment. And simultaneously, we work on a risk factor control.
Right.
Say like patient has concomitant hypertension, diabetes, that need to be controlled with appropriate medication. And also they are advised about lifestyle measure to be corrected. Someone is a smoker or chewing tobacco, all those things has to be stopped. So first line of treatment, obviously in both stable and unstable angina, is the medical treatment along with lifestyle modification.
Right. So viewers, what Dr. Sharma has outlined for us is that stable angina is the initial stage of coronary artery disease, and unstable angina, as the disease progresses, the patient begins to develop these symptoms even while at rest. Have I understood it correctly that both stable and unstable angina can be managed with medical management without the patient having to undergo any kind of invasive procedure?
On one side, I would say yes, but it depends on how the person responds to the treatment.
Okay.
If we go by the guidelines, yes, all these patients have to be initially managed with medical treatment.
Right.
And majority of these patients can stabilize.
Right.
See, the person who had stable angina, fixed block, and suddenly if his so-called cholesterol plaque ruptures and clot forms, so that he turns into unstable. So these drugs are known to stabilize. There's something called plaque passivation, that so-called inflamed plaque, which is responsible for superheated clot formation, that can be passivated with the use of this antithrombotic, lipid-lowering drug and nitrates.
Okay.
So majority of this drug patient can be stabilized. So on one side, there is a question of stabilizing their symptoms. They should be made comfortable. They should be relieved of symptoms. But those people who do not respond, or otherwise also those who have responded, we need to know the extent and severity of disease. So that's how they need a second line of investigation.
Right. So, sir, you have said that medication to take care of lipid derangements, antithrombotic medication.
Antithrombotic drugs are mainly to prevent the clot formation, because they are the so-called antiplatelet drugs.
Right.
So it is a bit different from the fresh clot which has formed and give rise to heart attack, and there we use clot dissolving drug. They are the separate class of drugs.
Right.
Now, as far as lipid lowering drug is concerned, yes, they are meant to lower the cholesterol, but at the same time, even the people whose cholesterol is normal, this medication are used, because other than lowering cholesterol, they have so-called pleiotropic properties, means they reduce the inflammation at the site of deposit of cholesterol, so that they prevent further clot formation and occlusion of the artery.
Right, right. So what I've understood is, as the disease progresses and it becomes more aggressive and the arteries become clogged and the plaque formation, on top of that, there is sometimes a clot formation. So initially, the cardiologist would treat these conditions with medication, but later on, when the disease becomes worse, the medication may have to be supplemented with some kind of invasive procedure also, if the situation so arises.
Yes.
So, Dr. Geelani, my next question is to you, sir. In the last episode, we had talked about annual health checkups and the requirement for annual health checkups. Sir, this is a kind of a hypothetical scenario. If an asymptomatic patient, a patient who has no symptoms of chest pain or breathlessness or any kind of typical symptoms that you had described, if such a patient is found in an annual health checkup, in a routine health checkup, right, to be in the initial stages of coronary artery disease. I mean, if the annual health checkup reveals that his lipid profile is deranged and there are abnormalities in his ECG and echo, then what would, and this is just a chance finding, the patient has no symptoms whatsoever. So in such a scenario, what would really be the course of treatment for such a patient?
Yes, usually these patients are the lucky patients who have got this the disease which has been diagnosed on on the routine checkup, and the patient is having no problem whatsoever, which can point that he is having the cardiac problem. So in this scenario, as Dr. Vinod has already mentioned, this presentation is varied. This variation is because there are so many complexity. Like we don't know how many vessels are involved. If it is a single vessel involvement or the double vessels involvement, or it is the triple vessel which is involved. So depending on that and how critical is the the stenosis and how rapidly it is growing. Your question is about the asymptomatic patient. We have to find out what is the functional capacity. It may be that he is doing all this work when he is doing the routine work, but when he has to exert and do something, then we have to find out whether his reserves are maintained or not, because the heart has got some reserve, but it may be functioning normally at the routine walking, but when he walks fast, well, it may not be, the blood supply to the part of the heart may not be adequate. So in that situation, we have to assess what is the functional status of that person, whether he is able to do the things or not. And it will be prudent to really establish what is the severity of the disease.
Right.
As we have discussed in the last episode, these are the patients who should go beyond the echo. Like the echocardiography we have picked up, now we should suggest they should go and they should get the CT angio as a screening done to further establish whether the patient is having the significant or critical block or not.
Right.
If it is there, then we have to go for the routine conventional angiography, which is what we call at the conventional coronary angiography.
Right.
So these patients are, and usually since these patients are hemodynamically stable,
right,
and the disease is most likely to be of lesser intensity, these are the patients who will be managed medically most probably, and they will get the maximum benefit on the, unless there is some very unusual finding which we can found on the coronary CT angio.
Sir, you use the word stenosis. Could you kind of simplify it for our viewers?
This stenosis means the narrowing of the vessels.
Okay.
Like if there is some blockage in a tube, that tube which is supplying the blood, that flow will decrease in that, because that the narrowest part of the tube will become the limiting factor, because the flow will depend on that narrowest part of the tube. So that is, we call it stenosis. Stenosis means basically the narrowing.
Right. So, sir, both of you have been treating patients of coronary artery disease for the last several decades. Do you find such scenarios to be quite common, where asymptomatic patients are found to be, in the initial stages of the disease? Is there a significant number of such patients?
Quite a good number of patients are like that.
Okay.
Especially since the time CT angio has come into the clinical utility. A lot of people, either themselves or suggested by the physician, they go for CT angio.
Right.
And they deny any kind of symptom.
Right.
And CT angio depict the disease. So as Professor Geelani said very clearly, that we have to treat the patient's symptom or his functional status. So some people who do not have symptom, but CT angio is showing the disease. So we have to go for another group of testing that is called as functional testing, either stress test or stress thallium.
Right.
So we come to know that these blockages which are shown in CT angio, even though person is asymptomatic, what is happening at the peak of exercise? Is it heart is not getting adequate blood supply? If that is so, then even though the person is asymptomatic, this patient require treatment.
Right.
But most of the time, these borderline disease which are found on CT angio, when the patient is asymptomatic, or if the functional testing is either mildly positive or negative, and they have to be managed medically, because we have to control the risk factor, and we have to see that unnecessarily intervention is not done in such patients.
Right. Dr. Sharma, from this hypothetical scenario of an asymptomatic patient who's found to have coronary artery disease, maybe in the initial stages, I'll turn now to a common enough scenario. I'm sure this is a scenario which is repeated quite often in most hospitals. That is, a patient is rushed to the hospital after having experienced breathlessness and chest pain, pain which is, as you described, radiating to the arms and shoulders, or even jaw pain or stomach ache. Now, such a patient is then on clinical evaluation, and after having undergone the tests that we discussed in the last episode, such a patient is revealed to have had a heart attack there. So then how is such a patient managed, sir?
See, once we have found that this person has either fresh heart attack or old heart attack,
Right.
these are the two scenarios.
Right.
Because a person can have symptom right in the point of presentation when he or she has pain or breathlessness. And ECG or echo may show it is a fresh heart attack.
Okay.
So the approach is different.
Right.
There are people who had a silent disease beforehand, and they present with some of the complication, like as a result of undiagnosed disease, their heart muscle is weak. So
Right.
they start developing sudden breathlessness. So that is mainly due to weakness of the heart muscle, and the ECG shows old heart attack, or echo shows evidence of old heart attack. So in scenario one, where the person has presented first time with the symptom, and ECG shows evidence of fresh heart attack,
Right.
then we have a standard protocol, which is
Okay.
practiced all over the world. If the person has presented to the hospital within 3 hours,
Okay.
rather within 120 minutes,
Okay.
approach is to take him for opening the artery with the help of primary angioplasty if the patient report to a center where there is a provision for primary angioplasty. Due to any reason, if there is a delay, or person present to a center where there is no provision, no facility for angiography and angioplasty, then they should be offered a clot dissolving drug, that is thrombolytic drug.
Right. Right.
Here our approach is, our objective is to save the heart muscle.
Right.
In setting of heart attack, time is muscles. As we lose time, we damage more.
Right.
So if we see the efficacy of primary angioplasty, it is helpful in restoring the flow and saving the myocardium, that is heart muscle, if it is performed within 90 to 120 minutes.
Right.
Most of the time in prevailing scenario.
Right.
Number two, if there is slightest delay, or a person is in a remote location where
Right.
the thrombolytic drug or clot dissolving drug is freely available, it should be utilized, because if it is going to help in any way.
Right.
Knowing the limitation that primary angioplasty is not available everywhere, it is not available 24/7. Patient cannot reach the desired hospital because of the traffic, because of the weather condition, or when they reach into the hospital, logistic delays. Like
Right.
in India, in at least we see it, insurance is not clearing, all those things.
Right.
Or people are seeking opinion. So it is now, last 5 years, there is a concept of so-called pharmaco-invasive therapy. Person presenting with heart attack, use the clot dissolving drug immediately, and whether he is in the hospital where there is a facility for angioplasty or not, or in a remote location, and after using the clot dissolving drug, some benefit is obtained, and within 24 hours, he can be shifted to a proper hospital where there is a facility, his angiography can be performed, and whatever residual blockage is there can be handled. Sometimes clot dissolving drugs are very effective, and we do not find any evidence at all of blockage. They dissolve the clot as a whole. So approach in setting of acute heart attack is to have either angioplasty or thrombolytic therapy, but decision should be quick. Whatever method we are doing, no delay should be permissible.
Right. So I would like to highlight this for our viewers, that time is of crucial essence in treating patients who seem to have had an acute incident of heart attack. If such patients are located in the hinterland of the country where, where hospitals with cardiology departments are not available to them, then I think the general physicians or the internal medicine doctors can treat them with these clot dissolving drugs, and these patients can be transported to the nearest city or the nearest town where an angiography and angioplasty can be performed. Is that right, sir?
Yes, ma'am. This clot dissolving drug,
right,
whenever there is heart attack, obviously periphery physicians can do. Nowadays, the general practitioner linked with the various hospitals through the many of these devices, they can transfer the ECG and decision can be taken in conjunction with a cardiologist.
Right.
And as it concept is there in the Western countries, so-called pre-hospital thrombolysis. Before they reach hospital in ambulance, even All India Institute of Medical Sciences has attempted and they have done quite a good job. So more this awareness is increasing in the periphery, and yes, we should attempt to salvage the heart muscle by using this clot dissolving drug as fast as possible.
It is not just cardiologists who have, of course, a primary role in treating such patients, but in giving treatment to these patients before they can reach a cardiology department, before an angioplasty can be performed on them. These clot dissolving drugs, which are of crucial essence. So my next question is actually addressed to both of you. So when a patient has had an acute incident like a heart attack, we hear of patients who are treated with angioplasty, as Dr. Sharma has described, and there are some patients who require a more invasive procedure, like what is known as, in medical parlance, as CABG, or what is known as bypass surgery for the lay people. So how do doctors choose which patient is more suitable for an angioplasty, or on which patient a bypass surgery needs to be performed? I would ask Dr. Sharma to respond to this first, and then Dr. Geelani, please respond to this question.
We have to divide this question into two parts.
Right.
One is that there is a patient who presents with the heart attack,
right,
as we discussed just now.
Yes.
So when he presents with the heart attack, and if he's within the time frame, and if we have taken him for angiography with the intent of primary angioplasty, so two scenario comes. One is that yes, only one artery is blocked, we open it then and there.
Right.
Then there is another scenario, we find that there is one artery which has blocked totally and is responsible for this episode, acute heart attack, so-called culprit artery. But there are blocks in other arteries also. So in that scenario, most of the time the practice is that we open the culprit artery,
right,
and we reassess those situation after stabilization.
Right.
Number two scenario is when we are doing angiography with intent of primary angioplasty, we may find that all the vessels are blocked and arteries are not suitable for angioplasty.
Right.
In that case, we use the so-called antithrombotic or blood thinner drugs. We stabilize the patient and hand over to the surgeon for surgery, which after stabilization they do. Second scenario is the person has no heart attack. He or she is getting just discomfort or pain on walking or moving.
Right.
Or he or she got unstable angina and we took patient for angiography.
Right.
And if we find that there is a disease, now the question comes what to do with the disease.
Right.
Whether we should do angioplasty or bypass surgery.
Right.
So even after 4 decades of refinement in the techniques and the devices and the drugs which are there, angioplasty is truly good for a lesions or blockage or stenosis which are localized at one point.
Okay.
It may be in one artery, it may be 2 artery, or even in the 3, but it should be localized without any calcification, so-called clean type of block. They are good for doing angioplasty with a good long-term result. But if we are finding totally blocked arteries, multiple blocks at in a one artery or in many arteries, diffuse block, there's a lot of calcification, calcium deposits over the artery. Those are the patients who do well with the bypass surgery.
Right.
When we are choosing the type of treatment for any patient, relatively stable patient, in acute heart attack, in any case, we have to look for opening the artery with the primary angioplasty, with a culprit artery. But when we are choosing the type of treatment for any so-called stable patient, our objective have to be three. A, the treatment should relieve his symptom.
Right.
B, the result should be long lasting.
Right.
And third, of course, it should be cost effective.
Right.
So if we are doing angioplasty in a multiple block or in a heavily calcified artery, they are not the patient who would behave properly in long term. They may come back with the symptom, recurrence of the disease at that point. So still, there are set of patients who qualify only for surgery. As I said, those who have multiple block, calcified arteries, in blocks in multiple arteries, they are the one good for surgery. There are patients who are good for angioplasty only.
Right.
One or two localized block without much of calcification. They are the patient who do with the angioplasty.
Right. Right.
Sometimes we find that in some patients, both are feasible.
Okay.
Lesions are suitable for angioplasty, but yes, in any patient, surgery can be done.
Okay.
So in that scenario, we have to take the patient risk factor and social and economic factor in totality to decide about the mode of treatment.
Right.
If the person is young, without much of risk factor, non-diabetic, especially non-diabetic, and localized block at 3 locations, yes, one can put a stent. But the same type of 3 location block, a uncontrolled diabetic, very non-compliant type of patient having multiple risk factors, better to offer him surgery, because surgical revascularization is still the long-term, so-called long-term patency is better with the surgical revascularization.
Okay. So before I come to you, Dr. Geelani, to get your take on this debate between angioplasty versus bypass surgery, I'd just like to explain it to my viewers that Dr. Sharma used the word vascularization. Both angioplasty and bypass surgery restore the blood supply, and that's known as revascularization. Right? Both angioplasty and bypass surgery are invasive procedures. Right? But Dr. Sharma has told us about the factors which go into the decision-making process as far as the doctor is concerned, which patients are more suitable for angioplasty, the extent and severity of the disease, the hardening of the arteries, calcification, multiple factors. And it's a very nuanced issue. Are the patients given a choice ever? Is there such a scenario where the patient is asked or explained?
Yes.
So is that a kind of consultative process between the cardiologist and the cardiac surgeon? Is there a kind of meeting where both the cardiologist and the cardiac surgeon, they arrive at a consensus?
Yes, there are few cases which are very straightforward, and there the cardiologists they usually take the decisions. But there is her team is there, which involves the surgeon and also the cardiologist, and they will take the combined decisions what is good for the patient, and then we have to take the consent of the patient, what the patient wants. If the patient is afraid of the surgery, then he can pursue medical management also. So it is up to the patient ultimately. We cannot ignore the patient's will in this, and but we can tell what is suitable for him, what is good for him, what is better. When we compare the two things, we have to tell what is better for you. The CBG or the bypass is better, or the stenting is better, or the medical management is better for you. But it is your decision you have to decide. And usually, when the patient is not seriously ill, like those who are not acute MI, there are many incidents. Those patients who will come with the acute MI, they have been advised since the time period has gone. It is now beyond 6 hours, so there is no use of doing angioplasty or the primary PTCA. So those patients are usually referred to, okay, you go and get the surgery done after few weeks, usually after 6 weeks. And if they, during this 6 weeks period, they realize that their symptoms are relieved and they don't want surgery. So they will say, can I postpone my surgery or can I avoid the surgery? Because this is a very complex thing.
Right.
The disease progress, how it progresses, and what is the natural history of this disease process, which is very difficult for a general person to understand. As very rightly said by Dr. Vinod, that the main purpose of all this intervention is to restore the blood. Means we have to again supply the blood, the earliest, the better.
Right.
So if we can do it by giving the drugs, we can do it by doing the angioplasty, we can do it by doing the bypass surgery.
Right.
Usually it has been seen that those people who are having it, whether they are having the hemodynamics compromise also, because the presentation of the patient are very varied. Some
Right.
patient will be having very only chest pain coming, lasting for more the continuous pain, chest pain. It means the patient has got MI. If it is an intermittent pain, we call it angina. That
Right.
will come and that will relieved on its own after taking rest or taking sorbitate, and then so we are having two type of sets of patients. One patient who are known case of coronary artery disease, and now they are having the problem. They are having chest pain, and there is another set of patient where there was no disease, and now they are coming first time with the MI or the heart attack, what you call in a general terms. So here the presentation are entirely different, because these patients who are known for coronary artery disease, they must have been taking some medicine. Those medicines are acting basically as a cardioprotective. They will decrease the complication of the myocardial infarction. They will first on the first line, they will prevent this acute attack from occurring. Even if it occurs, they will decrease the intensity or the severity of that disease, means it will become the disease mild.
So I'll turn to you, Dr. Sharma, now. Dr. Geelani used the word PTCA. I think in medical parlance, angioplasty is known as PTCA, sir. Can you describe angioplasty for us, sir?
Angioplasty, PTCA, that is a percutaneous transluminal coronary angioplasty.
Right.
We are puncturing the artery through the skin and reaching to the coronary artery, and in the coronary artery we perform the balloon dilatation and then deployment of a stent. That is precisely a coronary angioplasty.
Right.
Now the angioplasty, obviously we discussed which are the subset of the patient to be done. It is same as angiography. Simple puncturing the artery either of the wrist or the groin and putting the fine catheter and taking the picture, crossing the wire, crossing with the balloon and deploying the stent. Procedure sounds simple. It is simple though.
Right.
But yes, every patient has to understand one thing, that so-called concept surgery is very risky and angioplasty is very simple. That notion should go away.
Okay.
Still, the angioplasty in the expert hand, it still carries a risk of 1 to 1.5%. Artery may dissect, artery may tear off, artery may clot. There can be sudden death on table. There are a lot of things which can happen.
Right.
So, angioplasty technically it is possible, feasible in majority of the patient. When question comes which mode of treatment, I would like to add to what Professor Geelani said. Yes, we have to have a informed consent of the patient. Patient has to be informed in detail. What you said, for a layman to understand what is the calcification, what is the diffuse, what is the stenosis is difficult. But yes, by means of all tangible means of describing the disease or drawing the diagram and showing the picture, we have to inform the patient and patient relative, look, this is your disease. That's one. Second is, yes, we have to understand, and just now sir has nicely elaborated, that two things are very clear about coronary artery disease. Number one, coronary artery disease is because of the deposition of cholesterol inside the lumen of artery, and on top of that, there is a clot formation. This is a process of atherosclerosis.
Right.
So this process of atherosclerosis is a kind of a process in continuum.
Right.
It keeps on happening in body, everybody's body. Only thing is the degree and severity is differing depending on the risk factor profile.
Right.
And number two, the people who have this atherosclerotic narrowing of the arteries, whether it is of heart or anywhere else, this atherosclerotic disease, it has a phases of stability and instability.
Okay.
What makes them unstable and how they are stable, it is at times difficult to say.
Right.
A person absolutely healthy, no risk factor, something in his system took place and he develops clot and have a heart attack. Contrary, there are people who are a smoker, diabetic, eating left and right, whatever they want, obese, nothing has happened. There are people who had a heart attack. Somehow the heart attack was either undiagnosed or they dismissed the symptom saying it is a gas. But they keep walking, nothing happens.
Right.
There are people who had a very minimal symptom and they crash. So this, number one, the disease behavior is very unpredictable. And at times it is rather wiser not to predict about this unpredictable disease.
Okay.
Pick up the symptom, we pick up the diagnostic finding, and we have to intervene by appropriate means. And while deciding the mechanical revascularization,
Right.
whether it is by angioplasty or by surgery, yes, we have to inform the patient and family about the pros and cons of any of this procedure, and patient has to be party in taking decision.
Right.
Whereas the cardiologist and cardiac surgeon, we are not competitive specialty. We are complementing each other.
Exactly.
So when there is a disease, initially patient has to be treated medically, cardiologist role comes. When it comes to the diagnosis, angiography, cardiologist role comes. When it comes to performing intervention in a suitable patient, it is a cardiologist. But beyond a limit, or when the angioplasty, there is a complication, or if the patient cannot be handled with angioplasty, surgeon role comes.
Right.
After surgeons have performed, again, the patient has undergone revascularization. But body is his, blood is his, biochemical profile is his, genetic is his. He is going to develop disease again in the bypass arteries.
Right.
Again, the role comes for the cardiologist to make the patient adhere to the risk factor control.
Yes.
Should have a proper tailored medication so as to prevent the disease. Because angioplasty or bypass surgery,
Right.
neither mode is a curative. These are the palliative treatment.
Right.
We are turning the clock back. It will come again in the same point, the middle of the clock.
So the points that I've understood from your answer, sir, are that number one, it's a team of cardiologists and cardiac surgeons.
Yes.
They are not competitive. They work together for the well-being of the patient. The second thing, whether the patient is treated with angioplasty or with a bypass surgery, both these procedures are invasive, and what they do is they restore the supply of blood. But you also said that the disease process continues. It's a palliative procedure. It restores the supply, but it doesn't take away the disease. And unless these invasive procedures are supplemented by lifestyle changes, the arteries are going to get blocked again. Is that so, sir?
Yes.
Yeah.
Can I add?
Yes,
Hello,
sure.
can I-
Please go ahead.
Let me emphasize to the viewer again whether he has to undergo the revascularization by any need, medical management and lifestyle changes has to be continued, because what we are doing, we are just reducing the effect of a disease. We have to give some medical management to make the progression of this disease slow. That
Right.
has to continue lifelong.
Right.
So
Right.
the patient has to understand whether he has to undergo stenting or he has to go bypass surgery. These basic medications and the lifestyle changes has to be done throughout the life, and there is no escape from it. So any blockage which is more than 60%, that is a rough estimate. If it is more than 60% of the narrowing, it means this patient is most likely to develop some symptoms. If it is less than 60%, then it is very unlikely to have, and there is no need to do any intervention in that. The medicine will be enough to tackle that, any block which is 60%.
Right. So this is a bit of a digression for my viewers. A degree in cardiology, or what is known as DM, or a degree in cardiothoracic surgery, which are both of these are super specialist degrees. I think the training of these doctors requires from MBBS, I think at least 10 years, if not more. So the complexity of the disease, as both of you have outlined it, its unpredictability, the varied nature of the cases, all this involves for a case to case or a patient to patient treatment. One cannot just adhere to a standardized protocol. All these factors have to be taken into consideration. As Dr. Sharma had said, that there are patients who have all the risk factors but who don't develop the disease, and there are patients who have really no risk factors but they develop the disease. Right. So anyway, coming back to Dr. Sharma, you described angioplasty, sir. So angioplasty is a word which is, again, I think most people are familiar with it, though they may not know the exact nature of the procedure. I think you have explained it to us that it's a kind of a long, kind of a flexible tube which is inserted. It's a kind of hollow tube, I suppose, which is inserted into a blood vessel in the arm or in the groin area, and then it's kind of gently directed or nudged towards the blocked artery. Is that so, sir? Right. And this is and some kind of a balloon which is attached to the end of the artery. Is that then inflated to open the artery? Right. So, okay. Sir, we often hear patients talk about stents which have been implanted in during the course of angioplasty. Sometimes more than one stent is implanted. And we also hear of medicated stents. So if you could throw some light on what exactly is a stent in simple terms, what is it meant to do? And then, so what exactly does a medicated stent do, sir?
To understand the difference between medicated, non-medicated, and how they stent work, we have to understand that the coronary artery, which has a narrowing in the lumen, we are just taking the balloon at the site of narrowing.
Right.
Balloon is inflated. So when balloon is inflated, that so-called cholesterol plaque, which is narrowing the artery, that breaks by a kind of barotrauma. So when it breaks, obviously those inner lining of the artery, so-called intima, get disrupted.
Okay.
So it gets disrupted, and obviously if it is left like that, two things may happen. One is those disrupted intima, they may fall in the lumen and may block the lumen, so-called acute occlusion during the procedure.
Right.
Or if not, if they are okay, just they have a split.
Right.
Over a period of time, they may heal. And when they heal, obviously they create a scar inside, and they may narrow the lumen of the blood vessel again.
Right.
And what would be the extent of healing process in an individual patient, you don't know.
Okay.
Like we see that when we have a cut in the skin, sometimes the cut just goes away like a thin line and disappear after some time. But sometimes it forms a scar which is permanent. So likewise, when we are doing angioplasty, we are creating barotrauma and those internal lining of the artery is disrupted. So to prevent them from falling in the lumen and blocking the lumen, there is a stainless steel scaffolding that is called as a stent.
Okay.
So when you put the stent, obviously stent is in a metallic base.
Okay.
So stent itself will evoke certain reaction.
Right.
And tissue healing will take place around the stent and may block the artery again.
Right.
That's what we saw with the first generation of so-called non-drug coated stent.
Okay.
So now in the current generation of stent, they are the drug coated stent. There is a coating with a particular drug, which prevent the scar formation, so that artery which is opened and is scaffolded with the stent remain patent.
Right.
So that is the purpose of medicated stent.
Right. Sir, I'd like to ask you a little bit more about angioplasty. I mean, you did mention that there is a certain risk is associated with angioplasty also. I suppose all invasive procedures do have some kind of a risk associated with them. how long does the patient need to stay in the hospital, and after how long can the patient resume the normal rhythms of their life after undergoing an angioplasty and stenting?
See, the angioplasty, there are certain inherent risks which is in the range of 0.5 to 1%. As I mentioned earlier, when we are performing angioplasty, obviously it is under the radiographic control. It is not a three-dimensional image.
Right.
So artery may dissect, like when we are putting the wire, it may pierce. Balloons is inflated. When balloon is inflated, artery may rupture.
Right.
So those are the inherent risks. Sometimes wire is passed in and there is a clot formation there. Even after putting a stent, there may be clot formation. So those are the inherent risks which varies between 0.5 to 1%.
Right.
Now, angioplasty procedure per se, depending on the number of blocks and the type of artery, which is straight artery, tortuous artery, the procedure may vary from 10 minutes to 15 minutes to 1 hour.
Okay.
Patient normally have to stay for 2 days. We keep them for 2 days because after the procedure, first 24 hours, they have to be watched for so-called acute clot formation, acute stent thrombosis. So they are in the hospital for 48 hours. Now, after 48 hours, they are discharged and they are fully mobile. They move around. They are instructed to walk around. Now, coming back to their routine work depends basically on the circumstances which led to the angioplasty.
Right.
People who had a full-fledged heart attack and have undergone angioplasty, we ask them to have rest for at least a week, 10 days. And then they start resuming their activity like driving, cycling, all those things. So in a nutshell, most of the patients are back to their work by day 10th or day 11th.
Right. Right.
Some of the patients who are stable patients, they never had a heart attack.
Right.
They had symptom or in investigation, they are found to have blocked artery, they undergo angioplasty. Their heart function is normal. So they resume their work within a week, they can resume every work.
Right.
The patient, the rate at which they have to be allowed to engage in the activity or their immediate recovery, everything depends on one thing, about the strength of their heart muscle.
Right.
As Professor Geelani said, if somebody had a heart attack and has damaged the heart muscle and pumping capacity of heart function has fallen, so-called left ventricular dysfunction, that is the something which hinders everything. So all attempts should be made to preserve the heart muscle.
Right.
When they undergo angioplasty, most of the patients are discharged third day morning. They start walking, moving on the same day after the discharge. Day 7, most of the patients who are stable, they can go back to their work, they can drive, they can start moving around. And some patients who had a heart attack, we ask them to extend their rest for another 3-4 days, and they should gradually resume the activity. Some of the patients who have undergone angioplasty, but their heart muscle have been damaged because of heart attack, and if they had a symptom of heart failure in form of breathlessness, in them we ask them to go slow.
Right.
So it may take 2 weeks to resume their activity.
Right. Right. Sir, you talk about the heart muscle being damaged. Is this process of the muscle being damaged, can that damage be reversed in some way?
See,
or does it remain damaged?
Most of the time, the so-called heart attack or acute myocardial infarction, if the artery blocks and if artery cannot be opened or it was not being opened within the specified time, then that damage is so-called a scar. Most of the time it is irreversible. But the area of the heart muscle which is adjoining those scars, they are one which are salvageable.
Okay.
There are medications which are used to prevent the dilatation or enlargement of heart.
Right.
But whatever scar which has formed initially, most of the time this scar cannot be made to function again.
Sir, we also hear about words like ejection fraction rate.
Yes.
So can you explain that for our viewers? What does
Yes.
that mean? What does that indicate about the
Yes.
capacity of the heart to pump
Yes.
blood?
See, for all practical purposes,
Yeah.
if we talk about the structure of the heart, it has four chambers, two upper chamber and two lower chamber. Upper chamber are just a kind of a reservoir.
Right.
It is the two lower chamber which are concerned with pumping the blood.
Right.
So the left one is which is concerned with pumping the blood in entire body, and right chamber, right lower chamber, right ventricle is concerned with pumping the blood in the lungs. So it is the for all practical purposes, for the all heart attack purposes, and what we are talking about coronary artery disease, it is the left ventricle which is of most importance. Now, left ventricle receive the blood from the upper chamber, that is left atrium, and then it pumps the blood into the whole body. So suppose if the left ventricle receive 100 ml blood and pumps 55 ml blood, so that is 55%. That is ejection fraction.
Okay.
So in normal person, we see the ejection fraction varies somewhere between 55 to the 75% in athletes.
Okay.
So ejection fraction is the amount of blood which is pumped by the ventricle in each beat.
Right.
That is ejection fraction.
Right. Dr. Geelani, I'll turn to you now because we've had a good comprehensive discussion about angioplasty, its risk, etc. I'll turn now to the other invasive procedure, which is carried out by cardiac surgeons like you. So, sir, can you describe CABG, as it is known in medical parlance, or in simple terms, it is called bypass surgery? What exactly is done by you in bypass surgery? Can you describe it for lay people in simple terms without using any kind of technical language?
In a CBG, what we call, like you may see this bypass road, that bypass road. Bypass road is made to decrease the congestion when the road is going through one of the inhabited area. Like if it is, if the road is going through some busy area, then the government or the highway authority, they will make a bypass so that the time is there and the traffic can flow. So that is, they make the bypass. Similarly, the bypass is here also, that when there is a blockage, we usually bypass this area. We connect a tube from the aorta, that the artery which is the larger part of the aorta, we add it, and then this tube is connected to the block after the block. Because before the block, if we put, then there is no use because the road is blocked ahead. So you have to put this bypass road after the blockade. So similarly, we have to use a tube, and usually these tubes are natural tubes. We have to harvest, because when we take an artificial material, so there is a chances of the blood clot. Like Dr. Vinod said, like the stent is also, it is something like a spring made of metals. They have put a coating of some drug so that this blood clotting and the tissue in growth is not there. So when there is so we have to avoid the foreign material. So the bypass surgery is, the basic principle is to remove the obstruction and the ill effects of by using the natural material, not the foreign material. So the natural material which are easily available in the body is the either vein, the vein which is harvested from the leg, or we can use the artery which is of not useful to which we can take out without much ill effects. So there are few arteries which are there, like the what we call is the internal mammary artery, which is in the chest. Here it will be there in the chest on the both the sides, and that artery usually supplies to the chest wall. But what we can do, we can take out that artery from the chest wall, and one part is already attached. The other part we have to attach distal to the arteries where the block is. distal to the block. So that is known as the arterial graft. So the graft are basically of the two types. One is the arterial graft. It is said that arterial grafts are considered superior because the arterial grafts are used to high pressure. They are built to for the high pressure area. So, but the veins are not meant for. Veins are the low pressure area. They are meant for the low pressure area. So their structure is not meant to take care of the high pressure. When we take the coronary arteries, like the arterial graft, that is meant for this, and the size of that artery that also matches the size of the coronary artery.
Right.
It is something like that. If you make a very wide road and then afterwards there is a narrowing, so there is no use of making that wide road. The traffic will not flow. Similarly, we have to match the size of the coronary artery, whether it is, and the tube which we are using it, whether that is also matching the size of the coronary artery or not.
Right.
So this internal memory artery, what we said, right and left, it is found on the left side and the right side. Both can be used, and it should be used for the better longevity. It is said that those patients who are having the coronary, the arterial graft, they will have a long-lasting effects, and they will not develop reatherosclerosis, what we call the reatherosclerosis.
Right.
So these arteries will not develop reatherosclerosis, and they will not get a disease again, and at least for the next 15 years.
So, sir, if I've understood it correctly, the bypass surgery, or CABG as it is known in technical language, it involves taking a piece of an artery, preferably an artery and not a vein, and attaching it above or below the blockage, right? Is that so, sir? Right.
When we are taking off the artery, because the artery, the blood is already flowing. Right. So one end is already connected.
Okay.
So we have to just if that artery is big enough to reach distal to that artery, there is no need to put an anastomosis. We don't have to join at two places. We can join only at one place, that is distal to the obstruction. That is one thing.
Right. So, sir, you use the analogy of a road which is blocked in order to describe the blockage of the arteries, in order to explain it to lay people and how the bypass is created. Now I'll turn to the logistical part for the patients, because that's what affects them the most. What is the number of days that they need to be hospitalized in order to undergo a bypass surgery, sir?
That depends how motivated the patient is for the surgery, because we are getting two types of patients. One, patients who are really motivated, and these patients are mainly coming from the northern part, Punjab, and especially the army people. They are really motivated. They would like to move out of the bed on the day of surgery itself. They say, "Can I move?" And on the other hand, we are getting patients who are not motivated for surgery. They have been brought by their family members to get operated. So the motivation is very important. Patient should be motivated. He should say, "Yeah, doctor, I want surgery." Then not, because after the surgery, everything depends on the patient. We cannot do much. Because our roles are limited. Afterwards, the patient has to do two major things. One, the patient has to do the deep breathing exercises, which the patient may not do if he is not motivated because of the pain, chest pain, and other things. He will not do. Other thing, he has to take good diet, good balanced diet, which are rich in the protein, so that the wound can heal. I have seen the patients are fit to move out of the bed on third day. The patient can move, he can walk, he can come out of the ICU and by the fifth day he can move to the wards, and usually by 7th day they can go home. So the patient may be able to do the walking for 5 to 10 minutes initially. He has to increase for 5 to 10 minutes, 15 minutes, gradually. So by the end of the 2 weeks, he should be able to walk at least for half an hour. And after 6 weeks, he should be encouraged throughout life. A person can do a 45 minutes of walking. It means he is keeping his disease progression very low. So that is the first part. First thing is the walking and the physical activity. Second comes the disease and drugs medicines will come as number 2, and the number 3 will come to control of the risk factors.
Right, right. So, Dr. Geelani, I'd like to highlight for our viewers the point that Professor Geelani has said, that recovery to a large extent depends on the patient's motivation. If the patient is reluctant and reluctantly brought in for surgery, he's probably not cooperating or not following the doctor's instructions as much as he should. So, recovery and rehabilitation to a large extent are also, the factor of the patient cooperating and being motivated. That's important. What was interesting in the last answer that you provided was something to do with the diameter of the artery. So is that, you said something about the diameter of the artery being narrow and narrower among Indians vis-a-vis other populations in other parts of the world? Is that so, sir? Does
Yes,
our
yes.
ethnicity,
Yes,
does
sir,
the
because
geographical
this,
location, does that
yes, yes,
influence the diameter of our?
yes, it is because of there is ethnic variations,
Okay.
and even in Indians also. Even in Indians, if you take North Indians, Punjab, this part, Delhi, they have got a larger size of the coronary arteries when we compare it to the people from the south. We find that their arteries are very small,
Okay.
and it all build up how is the stature of the patient, what is the height of the patient. If the patient height itself is small, it means in that ratio, the coronary artery, everything will be of that size also.
Okay. So is the incidence of coronary artery disease lower in northern India as compared to southern India? That's too easy a correlation to make between.
No, it is not so easy to answer, but if you take the size of the coronary arteries and the diet habits, they
Right.
take lots of oils, like the
Right.
coconut oil, other oils, lots of things.
Right.
So the severity of the disease and the outcome of the disease after surgery and after angioplasty and stenting, it's not so bright when we compare to the air, like in the North India have although, because we have got some other this is a risk factor, because the diabetes is more prevalent in this part of the India than those parts. So ultimately, if you take the balance, overall the incidence will remain same.
Okay.
In both the things.
Okay. Sir, most of us are also apprehensive about undergoing invasive procedures. We talked about the risks involved in an angioplasty. And Dr. Sharma outlined for us that there is a minimal risk of 0.5 to 1%. What is the risk involved in undergoing a bypass surgery? Is that comparable to undergoing an angioplasty, or is it more?
No,
Because most people, when they think of a bypass surgery, it's like a big event, which it is undeniably. But the risk involved in an bypass surgery, how does it compare to the risk involved in an angioplasty?
No, the risk is almost 1% if the LV function is normal.
Okay.
If the LV function starts coming down, then this risk keeps on going up. Like if you operate on a patient where the heart function has almost 25%, means what is the normal, as Dr. said, it is the capacity of the pump, because no pump is 100% efficient. Like our natural pump is also only 60-65% efficient, and even in that, if there is a deterioration, if it comes around 25% of the function, then the risk will increase, and the patient will need the more time for ventilation. Usually the ventilation, like after the surgery, we keep the patient on ventilators.
Right.
But we usually remove those ventilator within 6 hours. After 6 hours, patient is off ventilator, and then he is breathing on his own. Right. But when these functions are, then we have to ventilate this patient for a longer time. Right. Because the lungs are very heavy in these patients, because the blood is collected in that. Because as Dr. Vinod said, between the lung and the LV function, the blood is not being pumped. So obviously this blood will keep pooling, will keep staggering there into the lung, and the lungs will become very heavy, and the patient will having the lots of difficulty in breathing, what we call the dyspnea. So the breathing problem is because the blood and water is collecting inside the lung, and which is making the thing worse. So obviously these patients will require some more period of ventilation. So the risk in those patients are around 5%. We can take the 5% risk if the heart function is less than 35%. And if it will be more than 10% if the heart function is less than 25%.
Dr. Geelani, my next question is also to you. We hear of patients who have undergone a bypass surgery some years back, and after an interval of some years, they develop symptoms like breathlessness or pain in the chest, and they are then advised to undergo a redo surgery. So, how does that happen? Is it because the process of atherosclerosis it continues unless one makes drastic alterations in one's lifestyle? So how can patients prevent the future possibility of having to undergo another redo surgery? What advice would you give to such patients who are undergoing a surgery now?
Yes, I will first answer this, why there is a need for the redo surgery.
Right.
The redo surgery is required when it can be either the patient is developing a disease in his own native arteries, like the coronary artery, which is there. They have developed a new obstruction, new stenosis, new narrowing. That is the one place where it can go wrong. Other thing, like the tube which we have used, they can get the changes and they can also get blocked. Or in few percentage of patients, there are some technical problem also,
Right.
where they can get it early. Otherwise, if these patients are having this problem, it is usually because of the new development of the lesion. The disease, one more lesion has developed. So in this situation, we usually avoid doing the redo surgeries. It will be dependent again, the same procedure will be the same algorithm will apply here, whether how significant is the disease, how many vessels the disease. If it is only a narrowing into the graft, and if it is localized, then our cardiologist colleague help in putting the stent in that, and the patient will get better off. Otherwise, what is needed is the assurance to the patient that yes, you are bound to develop, the disease will progress, and after 15 or 20 years, since the disease progression is very gradual, nature has got the time to develop the natural bypass. So you should not worry, and unless it is a very critical block, then only they should go for the reintervention. Redo surgeries are again done with the same intention, but the risk of the redo surgeries are almost double.
Dr. Sharma, I'll turn to you for my next two questions now. This is a rather embarrassing question for me to ask because it reveals a kind of distrust of doctors, which is highly prevalent nowadays. It's a issue which is rather embarrassing because I would rather not approach it, but still there is this kind of widespread impression among the general public that many of these invasive procedures are carried out even when they are not needed, right? That there could be some ulterior motives, that there could be some kind of commercial reasons for doctors to carry out. Please, I apologize for this very, very uncomfortable question to you, sir. Can you comment?
This is a very valid question in current context.
Yes.
And, with the more privatization, mushrooming of the corporate hospitals, too much commercial pressure may lead to such kind of practices. But I would advise, and I advise my patient, that whenever a question comes of it, taking decision about any intervention, I'm not talking about the patient with heart attack where he should not waste time. But when there is a stable patient who is found to have multiple block and someone is saying angioplasty, someone is saying surgery, somebody has been found to have in a routine checkup something and was asked to undergo angiography or any other procedure, I always ask them to take a second opinion, preferably from a teaching institution. Because teaching institution is more organized, still they follow the guideline protocol.
Right.
And they assess the patient from that perspective.
Right.
No doubt this kind of practice is there, it has crept into the system, and
Right.
probably we can't help.
Right.
But at the same time, patient have to be wiser and more consultative in taking decisions.
Right, right. So, as you say, you advise your patients to take a second opinion, but it should not degenerate into a kind of shopping for opinion, as happens sometimes, sir.
Well, that's what I say. They have to be given a final destination. So I ask them to, if at all they need a second opinion, they should go to a teaching institution.
Right, right. You had outlined for us the various risk factors which make it more likely for us to develop the disease. And if I had understood correctly, I think tobacco consumption, um, diabetes, uncontrolled hypertension, a deranged lipid profile, a sedentary life. These are the risk factors for coronary artery disease. Sir, we often hear in a day-to-day life, people talk about cholesterol without really understanding what cholesterol means, what are the ramifications. They use words like good cholesterol and bad cholesterol. And since a deranged lipid profile is one of the risk factors for developing the disease, many a times patients on their own begin to ask doctors, should they go in for cholesterol reducing drugs, or what kind of changes can they make in their life to reduce bad cholesterol or increase good cholesterol. So can you throw some light on this, sir? What dietary changes can patients or should patients make to reduce raised levels of bad cholesterol?
See, the lipids or the cholesterol, laymen
Right.
call it as cholesterol, but in a technical term, it is lipids.
Yes.
Lipids are essential constituent of our circulation.
Yes.
Now, out of these lipids, various components are there:
Right.
triglyceride, total cholesterol, low density cholesterol, high density cholesterol.
Right.
Out of all these, it is only the high density cholesterol, which is the so called good cholesterol. It pulls the cholesterol out of the wall of the artery. But LDL, that is the most important culprit, low density cholesterol, low density lipoprotein, that is the most important culprit. Now, the objective is to keep the cholesterol, total cholesterol under control and lower the LDL as low as possible. Normal range of LDL is something within 120 milligram per deciliter. But for normal prevention, we recommend that it should be preferably within 100, and those who are already diabetics or have suffered heart disease, it should be brought down below 70 milligram per deciliter. As far as LDL, that bad cholesterol is concerned, the guideline says lower the better.
Right.
HDL is one good cholesterol, yes, that is there, and SDL can be enhanced in the circulation simply by exercising. There is no specific medication. Some of the cholesterol lowering medication are known to increase HDL, that is a protective good cholesterol, but they are marginal.
Right.
Now, what is exactly the thing can be controlled? This cholesterol or lipid can be controlled. We have to understand one basic fundamental thing is that cholesterol is produced by two sources. It is in our body by two sources. One, what we are eating, exogenous, and one, what our liver is producing. So that's how many a time there are people who are thin, who do not engage in any kind of dietary indiscretion. Still their cholesterol is high because liver is producing. So we have to tackle both the arms.
Right.
Initially, we asked them to strictly go for so-called low-fat diet. Low-fat diet means avoiding all fatty food, cheese, butter, ice cream, all sweet drinks, because they ultimately get converted into lipids, and that is the cholesterol. So first aspect is the controlling the diet. Second is they have to engage in exercise.
Right.
At least 45 to 50 minutes walk per day for at least 5 days in a week.
Right.
And third is that sometimes they engage in both the things, still lipids are not coming down. Or we find high cholesterol or high lipid in a person who already has a risk factor. He's a diabetic, he has a family history. So they have to be given a drug which lowers the cholesterol by inhibiting synthesis from the liver.
Right.
So there are cholesterol lowering drugs that is to be instituted. So in a given patient, especially if he has a multiple risk factor and if his lipids are elevated, then all the three arms have to be applied equally. That is a dietary restriction, exercise, and drug.
Right. Right. So, viewers, we've had a thorough and absolutely comprehensive discussion about the various aspects of coronary artery disease. What is a major takeaway from this discussion for me as a layperson is the fact that the disease is to a large extent a lifestyle disease. So, since prevention is better than cure, if we adopt a healthy lifestyle, which includes, as Dr. Sharma said, taking a healthy diet, low in fats, exercise regularly, give up tobacco consumption, manage our hypertension and diabetes well, we are on our way to leading a relatively coronary artery disease free life. But friends, despite all these measures, God forbid, if we were to develop the disease, then there are treatment options available. So let's not despair. And both the doctors have outlined these treatment options for us in a very reassuring manner. So let's conclude today's episode on this very, very optimistic note. I'd like to conclude this episode by thanking both the doctors who have shared their time and knowledge so generously. Thank you, both of you. Please post your feedback in the comment section below. Thank you, viewers, and thank you, doctors. Stay informed, stay healthy.